So, we all know that PRP is the need of the day. It's widely used in dermatology, plastic surgery and orthopedics. So, today we will discuss the role of PRP in orthopedics. So, it was first started in 1970 and it was used in 1987 in open heart surgery, and it gained popularity in mid 1990s, and it has been reported that Tiger Woods, who is the well-known name in golf, he had a knee injury, and when he got PRP and it was successful, so it gained much more popularity and it was then widely used. So, if we look at our blood, the main components of our blood is 55% of it is plasma, less than 1% is leukocytes and platelets, and 45% of it is RBCs, while in our PRP we have 94% of platelets and plasma and only 5% of RBCs. So, it is basically platelet rich plasma. So, we utilize the growth factors which are secreted by platelets to aid the healing of our musculoskeletal tissues, and predominantly we use them in tendons, ligaments and muscles. So, the high concentration of these growth factors, they are deposited locally in the area of the injury, and the anabolic effect of the growth factors enhances and supports our healing. So, the body responds to platelets and they basically proliferate the mesenchymal stem cells in that area, and there is proliferation of fibroblast and type 1 collagen, which are the main two things in our healing scar. The main growth factors present in our PRP are PDGF, TGF beta, FGF, insulin like growth factor 1, 2 and so on. So, basically it leads to chemotaxis and cell proliferation. In chemotaxis, they attract the stem cells, and then later on they are activated by these growth factors, and in cell proliferation we proliferate the mesenchymal stem cells and the fibroblast. So, in summary, we would say that through a complex series of biochemical and cellular events, these growth factors cause a rapid and sustained increase in the number of mesenchymal cells and fibroblasts in the area, and then cause stem cell maturation and thus promote healing. So, what are the advantages of having leukocytes in our PRP? So, the pure PRP has the advantage over the traditional PRP in that it eliminates red blood cells and neutrophils. The RBCs, if they go in much number in the PRP, it will cause more pain while injecting. The neutrophils component of the WBC, they are a potent inflammatory component, so they will cause pain post treatment. But the beneficial effect is that in presence of neutrophil, platelets secrete arachidonic acid, which is taken up by the neutrophils, and neutrophils secrete leukotrienes and prostaglandin. These two are potent inflammatory components, but the leukotriene component is taken up by the platelets in the presence of neutrophils, and they secrete lipoxin. Lipoxin has a potent anti-inflammatory effect, and we use this lipoxin effect as the anti-inflammatory component of the platelets. So, if we inject local anesthetic along with PRP, it will reduce its activity because the pH will be changed and the platelet will not work in their own way. So, there is a long list of use in orthopedics. The osteoarthritis is the topmost, which we use mostly in our practice. Then tendonitis, plantar fasciitis, rotator cuff tear, meniscal repair and so on. There are no much complications of PRP and there are no adverse effects because it's own blood, there is nothing added. The symptoms may worsen for a few days because of the inflammatory effect of the neutrophils. The infection is the most worrisome thing, but if we clean it and we take care, so most probably it will not happen. The symptoms may persist if we are not injecting it in the proper indication, so it will not work. We should avoid वापस नहीं जाता We should avoid PRP injection in patients who are thrombocytopenic, who have cancers, who are on any anticoagulants, or they are taking steroids. So usually we take 10 ml of blood for one PRP. We put it in a vacuum tube having sodium citrate as an anticoagulant and a gel in it. So we centrifuge it at 3600 RPM. So there are two schools of thoughts. Previously they used to centrifuge it initially at 1000 in the first step, then they used to take the plasma and put it in another tube and then centrifuge it at 2000 RPM second time, and then the PRP was made. But now they have the research that at 3600 RPM we can use it only once and we can take the PRP. So it is at the inclination of 45 degrees for around 8 to 10 minutes, and we obtain around 6 ml of PRP from the 10 ml of blood. So here you can see that the RBCs and cells are here. This gel is the separation between the PRP and the cells, and the top one is our PRP. So these are some literature review for the main indications of PRP in orthopedics. So in osteoarthritis, we mainly use it in grade 1 and grade 2. In grade 3, its use is questionable, but in grade 4 there is no effect. So they have used it in grade 1 and grade 2, and they reported that at 1 month there was pain improvement, but at 6 months it was much more. So we use it at in monthly interval, 1 dose of PRP, and after 3 months then we stop it, and then we review them after 6 months. If they need another PRP, then we can give them after 7 or 8 months. The tennis elbow, which is basically the tendonitis of the lateral epicondyle of the humerus. In this they have this prospective multicenter study. They reported that there was no much difference at 12 weeks, which is 3 months, but at 24 weeks they found a meaningful improvement, and which was long lasting. Plantar fasciitis, it's very difficult to treat. Most of the patients, they are chronic, they get steroid injections, then they rupture their plantar fascia, and it's very debilitating for the patient. So they have this prospective study. In this they show that they had a considerable improvement in the plantar fascia. They did the ultrasound, and on the ultrasound they found that the thickness of the plantar fascia, it was regained, and the symptoms were subsided. So avascular necrosis of the femoral head, it's a very challenging topic in orthopedics, because we cannot control it, we cannot stop it, and once it happens it will go on. So in stage 1 and stage 2, in which there is no collapse or deformation of the femoral head, we can in some way limit the progression by doing core decompression, putting stem cells in it, and bone grafts. So if we use the PRP along with that, it will induce the osteogenic effect and will stimulate the stem cells which we are putting in them. So it will have an added benefit on it. Rotator cuff tear, which is mainly occurred in middle age and old age people. These are the 4 main stabilizers of the shoulder, and supraspinatus is the main one in which we get the tears. So it is very well treated with PRP if they are the partial tears or less than 1 centimeter. So if we treat them with the PRP, they will relieve the symptoms, and to some extent they will also get the power of the rotator cuff. Coccydynia, it's a very one more challenging thing in orthopedics. Patients are never happy, whatever we do, they are lingered on. So there are some case reports. There are no much prospective studies, but there are case reports that the patient got benefit from it. Like in this patient, they gave 3 injections, and the patient reported benefit at 30%, 70%, and 85% after every injection. So at 6 months, the patient continued to experience the same level of reduced pain which he got at the end, which was 85%. Thank you.
When you prepare the
because in cancers the patients are immunocompromised, so if we give platelets, there will be no body response to it. and they can have infection also. If we are putting PRP in knee joint in an immunocompromised patient, there are more chances of infection. So if the joint is infected, it's gone. The plastic surgeons, they do flaps for us. We don't do it ourselves. Yeah. We haven't done it. The plastic surgeons may tell you better, but if you see the growth factors which are present, so they have vascular endothelial growth factor, so they will promote the angiogenesis. So it may have effect, but when you are putting this, the patient should be off the chemotherapy. Yeah.
I'm talking about during surgery.
No.
When we have placed the flap inside,
Yeah.
and then maybe we can use this.
So once chemotherapy is finished, patient's immune system is okay, then you can use it. But for the flaps, I think the plastic surgeon would be a better person to tell you. Yeah, there is a thinking that blood also is helpful, but if you are giving platelet, there is more concentrated platelets going in. So we are taking use of that. There is a comparative study, I forgot to put it. I took it out, but I forgot to put it. There is a comparative study of PRP with these hyaluronic injections, and there is comparative study of PRP, steroid and hyaluronic. So in all of them, the initial effect of steroid is better, but the long-standing effect of PRP is better, because steroid will give you effect for 1 or 2 months, but the PRP effect sustained for many months. Grade 1, grade 2 don't give steroids, because steroids itself destroy the cartilage. So keep it for stage 3 or stage 4. Stage 1, stage 2 either give PRP or you can give hyaluronic, but there is no much data of hyaluronic in favor of its response. In the NICE guidelines, it's not approved hyaluronic. So they only approve PRP in stage 1, stage 2 and steroids for later stage 3, stage 4.
Oral hyaluronic, converting sulfate and hyaluronic.
Yeah. The studies don't support it. We don't have the machine here, but we have the tubes. We call the vendor, they bring the centrifuge and then we use it. जो हमारी लैब की जो सेंट्रीफ्यूज है उसका RPM इतना नहीं है, इसका RPM ज़्यादा है. तो एक मशीन अगर हम ले लें तो हमारा अपना हो जाएगा.
लैब में भी काम आ जाएगी.
वो लैब वाले पता हो कि ये RPM उनको यूज़ करता है ना, लेकिन इसका RPM लैब से ज़्यादा है. Some of our friends, they are making the PRP on the basic centrifuge of the lab. Their effect is also okay. They say that the patients are getting the effect. Anticoagulant. In this tube we have anticoagulant. No, actually these tubes, they have sodium citrate. So it's anti. Yeah. So आपके वाले में ये नहीं होता था ना, तो इसलिए वो जेल बन जाता था. तो इसमें anticoagulant होता है तो इसमें जेल नहीं बनता. If they are in stage 1, stage 2, like in osteoarthritis, yes, we can give. In stage 3, it's questionable. We can give, but with guarded prognosis, explained that it may work, it may not work. In stage 4, it doesn't help. You can use either steroid or just replace it. Symptom-wise, if the pain has just started and they are just complaining now, and you see X-rays are not that much bad, so we can give it so that. So usually the patients, if they have started pain now and we give it now, so after 1 month when they come for the second dose, they say that we are not taking any painkillers now. Yeah. So most of the patients at second dose, they quit. If they are taking Panadol on regular basis, then yes, we can give this to quit that regular Panadol. But if they are taking it occasionally once a week, then you can wait. Like clopidogrel, yes. For aspirin, no need. It's widely used by plastic surgeons, especially for hair transplant and their scar revisions. Thank you.